Hey, future RNs, and welcome to ClearPath NCLEX. Listen, if you're studying for the big exam, you know coronary artery disease is a huge topic. But don't you worry, because today we are going to break it all down step by step to make sure you feel totally confident. I know. CAD can feel overwhelming, right? There's just so much to remember. But that's exactly why we're starting here with the absolute basics. We're going to build a really solid foundation together. So go ahead and take a deep breath and let's jump right in. We can do this. So here's our game plan. First up, what even is CAD? Then we'll dive into how it all happens. We'll cover the key risk factors, the signs and symptoms you need to watch for, and how doctors diagnose it. And then, to wrap it all up and make sure it sticks, we'll do a quick NCLEX practice drill. Sound good? Let's go. All right, let's start at square one. What exactly is coronary artery disease? Let's get this foundation set. Okay, so in the simplest terms, think of CAD as a plumbing problem in the heart. You have these special pipes, the coronary arteries, and their only job is to bring oxygen-rich blood to the heart muscle itself. With CAD, these pipes start to get clogged up with this gunk, this fatty plaque. As the plaque builds up, the artery gets narrower, and that means less blood can get through. The heart muscle starts getting starved of oxygen, and that's where the trouble begins. And what's the name of this clogging process? It's a huge NCLEX keyword, atherosclerosis. You might have heard it called hardening of the arteries. This one process, atherosclerosis, is the main cause of CAD. So burn this into your brain. When you see CAD on the exam, you should immediately think atherosclerosis. So how does a perfectly healthy artery get clogged up and hardened? Let's walk through the pathophysiology, the step-by-step story of how this happens. Understanding this process is everything. It all kicks off with an injury, the tiny bit of damage to the smooth inner lining of the artery. Things like smoking or high blood pressure are common culprits that cause this initial damage. Once that wall is injured, it gets kind of sticky. And that's when the bad cholesterol, LDL, starts to glom on, forming these little fatty streaks. That's step two, the start of a plaque. Over time, more and more junk, fat, cholesterol, calcium piles on, making the plaque bigger and the artery narrower. But here's the most dangerous part, step four. That plaque can break open or rupture. When that happens, the body freaks out, thinks it's a major injury, and sends platelets to form a blood clot, a thrombus, to patch it up. The problem? That clot can totally block the artery, stopping all blood flow, and that's what causes a heart attack. Okay, now that we know how it happens, let's talk about why it happens. What puts someone at a higher risk for developing CAD? For the NCLEX, you absolutely have to know the difference between the risks a patient can change and the ones they're stuck with. Let's start with the modifiable risks. These are the ones you can change, and they are so important for patient teaching questions. We're talking about things like smoking, having high cholesterol, specifically that high LDL, high blood pressure, diabetes, being overweight, not getting enough exercise, and eating a poor diet. These are all things we can help our patients work on. Then, on the other side, we have the non-modifiable risks. These are the things you just can't change. We're talking about age, gender, men and postmenopausal women are at higher risk, and, of course, family history. You can't change the hand you were dealt, but it's crucial to know about them for a full risk assessment. So what does CAD actually look like in a real person? What are those classic signs and symptoms that should set off alarm bells in your head? The number one symptom is chest pain, also known as angina. But you have to know the difference between stable and unstable angina. Stable angina is predictable. It's the patient who says, yep, every time I walk up a hill, I get that chest tightness, but as soon as I stop and rest, it goes away. It happens with exertion, and it's relieved by rest or nitroglycerin. Now, unstable angina, that's the scary one. This is chest pain that's new, or it's getting worse, or it's happening when the person is just sitting on the couch. Rest or nitro doesn't make it better. This is a true medical emergency. And here is a massive NCLEX pearl for you. Not everyone gets that classic crushing chest pain. Women, older adults, and patients with diabetes are notorious for having atypical symptoms. So you have to be on the lookout for complaints like extreme fatigue, just feeling wiped out for no reason, shortness of breath, or even pain in their jaw, their neck, or their back. These can all be signs that the heart is in trouble, so never, ever dismiss them. Okay, so a patient shows up with some of these symptoms. How do we figure out if it's really coronary artery disease? Let's check out the diagnostic toolkit. So we have a few key tools in our belt. We'll definitely start with some blood tests, specifically a lipoprotein profile to check those cholesterol levels. We'll get an ECG or EKG to look at the heart's electrical rhythm. A stress test, either on a treadmill or with medicine, is great for seeing how the heart performs under pressure. But the gold standard, the test that gives us the best look, is a coronary angiogram. That's where we can actually go in and visualize the arteries to see the blockages. Let's really zero in on the EKG because this is so important for your exam. ST depression, think D for down, means ischemia. The heart muscle is being deprived of oxygen. It's serious, but it might be reversible. Now, ST elevation, think E for emergency, means injury. The heart muscle is actively being damaged right now. This is the classic sign of a myocardial infarction, a heart attack. All right, take a deep breath. We have covered so much. Now it's time to put that knowledge to the test with a few NCLEX-style questions. Ready to see what you know? Let's do this. Okay, question 1. A client gets chest pain during his morning walk, and it goes away when he rests. What's going on here? Take a second to think. And the answer is 3. Stable angina. You got it. The key words here are predictable, happens with exertion, and is relieved by rest. That is the textbook definition of stable angina. Question number 2. Which of these is a non-modifiable risk factor? Which one can the patient not change? The correct answer is 3, family history. Remember, things like your family history, your age, and your gender are the things you can't do anything about. Smoking, lifestyle, and high cholesterol are all modifiable. They can be changed. All right, last question for our drill. What's the main ingredient in those fatty plaques that cause all the trouble? And the answer is number 2, low-density lipoprotein, or LDL. That's our bad cholesterol. It's the sticky substance that kicks off that whole plaque-building process. You guys did awesome on that drill. Seriously, great job. That is it for part 1. You've just built an amazing foundation for understanding CAD. But we're not done yet. In part 2, we're going to talk all about what we, as nurses, do about it. Priority actions, key medications, and all that crucial patient teaching. So be on the lookout for that. Thank you so much for watching. If this was helpful for you, please hit that like button and subscribe so you don't miss out on any more high yields content. And hey, drop a comment below and let me know which risk factor for CAD is the one that always sticks in your mind. Keep up the amazing work. You are studying hard, and it is absolutely going to pay off. You've got this. I'll see you in the next one.